you.
To introduce Dr. Silvia Rosa. She received her dental degree from CES University in Medellin, Colombia, and her postgraduate degree in periodontics from the University of Illinois in Chicago. She's a diplomat of the American Board of Periodontology. She served as president of the Pierce County Dental Society from 2016 to 2017, where she was a member of the Board of Trustees and then an executive member participating in multiple committees. She's been quite active and has served as a member of the Board of Trustees for the Pierce County Dental Foundation. She has incorporated dynamic surgical navigation in her practice since August of 2017. Striving to better serve her referring doctors and patients and improve clinical outcomes, she's been very instrumental in providing feedback to the Navident team to enhance the technology. Dr. Silvia Rosa is in private practice with Dr. Manuel Rosa, both in Tacoma and Gig Harbor. Together they combine and treat all aspects of periodontal, oral maxillofacial surgery, dental implants, pathology, and aesthetics, utilizing all aspects of surgical dentistry and anesthesia. One of the things that our speaker may not know is, I think, other than Bob Summers, I think I may have written the first papers on transcrestal navigation. I've written ones with Dave Anson, who can't be here, and I'm putting together a study with Ziv Mazer and potentially with Greg Kurtzman, who's on board. So, Silvia, it is going to be a pleasure and an honor to listen to you tonight. You have the stage.
All right. Dr. Horowitz, thank you for the kind introduction. Good evening. I am thrilled and honored to be sharing this webinar with Dr. Horowitz. First, I would like to give thanks to claronav for the invitation to share my experience with you and to ViewMedi for making this webinar possible. As a disclaimer, I have no financial ties to claronav. All my clinical photos and my videos are original and have only been adjusted for speed or insight. As a clinician, I am doing this webinar because I want to share with you my experience on how dynamic surgical navigation can assist you in transcrestal sinus augmentation, and to definitely get you excited as I am to better serve our patients. So what I want for you to learn tonight is how dynamic surgical navigation can assist you in transcrestal sinus augmentations, eliminating the need for both guides and direct visualization. Second, I'd like for you to learn how to plan a case on the software for navigation and also learn the workflow through case presentation. And last, I want you to become familiar with a combination of technologies: dynamic surgical navigation in combination with DensaBird technology for identification and the hatch rimmer technique and technology, so that we can actually obtain a highly accurate and precise restoratively driven implant placement, improving both the patient's outcomes and the patient experience. So we're in this together, and I need to explain first of all what is dynamic surgical navigation. So dynamic surgical navigation is a computer-guided freehand technology that allows for precise and accurate surgery in real time through instrument motion tracking. And how does it work? It works much like a global positioning system, where your satellite is a micron tracker camera or an optical positional sensor camera, which is tracking in real time the trackers that are placed on the patient and on your handpiece. The video stream is then taken back to the computer, where the exact calculations of the three-dimensional position of those trackers are relative to the camera. And that is what you see on the screen. So your CVCT becomes your roadmap. So again, much like a global positioning system, but that of an aircraft, because it's allowing to see all three positional planes, the X, the Y, and the Z, and this permits for great accuracy and precision for our procedures, especially in our case, for the placement of implants. We know now that the technology is actually expanding to the field of endodontics, not only to treat endodontic canals, but to actually access calcified canals and again treat them. With the evolution of techniques, technology, biomaterials, imaging, sinus graftings have grown to be a very common and predictable procedure. Let's review in history where transcrestal sinus augmentations through 3 different eras. We first look at from the Renaissance to the 17th century, the maxillary sinuses and their function were described. We must remember then from Leonardo da Vinci all the way to Dr. Schneider. Second era, from the 17th to the 18th century, the maxillary sinuses were accessed so they could be for treatment of sinus disease. And we remember here Dr. Desolles, Dr. Lamoliere, as well as Dr. Scalwell and Dr. Locke. And last, we have from the 20th to the 21st century, where the maxillary sinuses have been accessed for the purposes of augmenting them, so we can actually place implants. We must remember here 3 important clinicians, Dr. Tatum, Dr. Boyne, and Dr. Summers. So in 1974, Dr. Tatum actually modifies the Calvert lock technique, and he accesses the sinus floor from the crest. And then he modified his own technique to access the sinus floor from the lateral window. Then it is Dr. Boyne in 1980 who, after placing a bone graft on the lateral window, he publishes the technique. And then Dr. Summers in 1994 actually publishes the osteotomy-mediated sinus augmentation with immediate implant placement. And we know from various clinical case reports and retrospective studies on the success rate of the osteotomy-mediated technique, including that of Dr. Horowitz. Dr. Horowitz, truly, thank you for your collaboration. I didn't know that. So let's go over the long-term implant survival rate on the augmented sinuses. We must remember the systematic review by the Favreau and collaborators, where they evaluate implants with a minimum of 3-year follow-up post-loading, and the range was from 3 to 10 years. They found that the implant survival rate on augmented sinuses was 93.7% for the lateral window approach and 97.2% for the transcrestal approach. They also found that 80% of the failures occurred within the first year post-loading. And we need to look now at most current literature on the transcrestal approach. On osteodensification, they have actually encountered the same success rate at 97%, and the hatch trimmer technique and technology also was between 95 to 96%. So with the Favreau's systematic review, not only they wanted to find out what was the implant survival rate on the augmented sinuses, but whether the type of graft, the implant surface, the insertion time, the residual bone height, the membrane utilization, the timing of failure, the publication date, the study design, and whether bone graft was applied at the sinus at the time of the transcrestal approach or not, whether all these factors affected the implant survival rate. And what they found is that the long-term implant survival rates are better when we use a bone substitute on a rough immediate implant, independent of the residual bone height of lesser or equal 5 millimeters, and when a membrane was utilized. Regarding the timing of failure, as we had said before, 80% of the failures occur within the first year post-loading. Between the second to the third year, the implant failure rate went down to 12.6%. And then after 3 years, the risk went down to 0.43%. And the risk is a risk. Basically, it's a potential. It doesn't mean that all implants will fail. However, if you cross the third year post-loading, you're golden. And if you lose an implant at that point, you must know that it's not related to the type of implant you placed or the type of graft or augmentation you did. It is probably related to mechanics or to peri-implantitis. And regarding peri-implantitis, we must remember the 6 European consensus report on peri-implant disease, where peri-implantitis incidence rate from 12 to 40%. So it is our responsibility truly to educate our patients on not only periodontal disease, but peri-implantitis, so we can have long-term implant survival rates. And regarding the transcrestal augmentation, they found that it did not make a difference whether a bone graft was used or not on the transcrestal approach. We're all clinicians, and we definitely use different techniques, different technologies. I will tell you that me, as a clinician, in my experience, I like to use either a bone graft or a biological or both on the transcrestal approach. In an effort to achieve greater simplicity with reduced complications, various techniques have been developed to simplify the osteotomy-mediated technique. I personally have been using the reamer-mediated or hatch-reamer technique and technology since 2008, and the osteodensification through the Dentistry technology since 2018. Combining technologies to a procedure that we all know so well, and that truly has worked so well since 1994. For me, I was in the search of a technique that actually will improve the patient experience. Now that the osteotomy-mediated technique did not work, we know it works, we all have used it, but I really wanted to eliminate the percussive force of the mallet, and I wanted to simplify the infracture of the sinus floor. So it is in 2008, when we started using the reamer-mediated technique and technology, that I started using a mallet for this procedure. And since 2017, when we incorporated navigational technology, it was the perfect synergy. Combining these technologies not only improved the patient experience, but the accuracy and the precision, so improve the patient outcomes. The importance of both accuracy and precision has been very eloquently described before by Dr. Horowitz, Dr. George Mendeleris, Dr. Lipton on previous webinars and on previous presentations. I definitely invite you to learn from them. I know they're in View Media as well. But in review, let's look at what is accuracy. So accuracy refers to how close the measurements are to the true value. And precision refers to how close the measurements are to each other. When we review studies on accuracy, it is important to combine publications and make a distinction between fully guided and partially guided, especially in vivo, to understand the advantages of navigational surgery over a static guide, both fully digitally made and conventionally made, and of course over freehand. So the data here shows that at the mean entry point deviation, a static guide actually performed similar to one of the navigational technologies, X-Guide, but underperformed next to the older navigational technology, Navident. At the mean apical point deviation and the mean angle discrepancy, both navigational technologies overperformed when compared to static guides and to freehand. Yet when you compare both the navigational technologies, Navident surpasses the accuracy at all levels. This data here, this slide, should be as meaningful to you as it is to me. You can see here from the left to the right, actually from freehand technology to static guide to navigational surgery, how much better we're doing for our patients. This is actually electrifying, and I can't wait to see what is yet to come. So now let's review cases where dynamic surgical navigation was done in combination with the hatch-reamer technology and osteodensification through the Dentistry technology to obtain the transcrestal sinus augmentation. So in our first case, we will review, again, navigational technology with osteodensification. So here, Ms. Rollins was referred to our practice so that we can deliver for her, or provide to her, first molar occlusion. I staged the care for her, and tonight I am only presenting the area of number 14. And what we did is we first obtained a CBCT and an intraoral surface scan. With the intraoral surface scan, we're going to create an ideal restorative virtual plan. And then we're going to merge both the DICOM file from the CBCT and the SEO file from the intraoral scan. You can see here my residual bone height was 7.5 millimeters, and I'm staying shy by 1 millimeter so we can do the transcrestal augmentation. And we're actually planning through the virtual ideal restorative plan. The first thing I do is I select the landmarks. The software requires that we select 3 to 6 landmarks. We want to do this as close as possible to the incisal edges. Then we get our patient comfortable and we create a small access flap. And from here we're going to get our patient ready to initiate the navigation. So we provide her the head tracker and we bring close to the field the calibrator, the tracer tool, and she definitely looks so cool. She's really excited to go. So we start the navigation by scanning the barcodes. We then will calibrate our tracer tool. And that is so we can actually do the trace registration. Now, trace registration is the means by which we can register the patient's jaw to her CVCT. And we do this by tracing 100 points per tooth or per landmark chosen. This is the only time you see me looking at the patient and not looking at the screen. We're actually in full contact with those teeth. Now we proceed to do the accuracy check. This is to know how accurate our tracing was, our registration was. We do this in all surfaces, the occlusal, the buccal, the lingual, the interproximal. Now we do the drill access and drill tape calibration. And from here we're going to check again the accuracy. This is very important. You want to do this at every time you change the drill bit. We check again on the buccal, the occlusal, and the proximal. And now we initiate the navigated osteotomy. We first start with a pilot drill at 800 RPM, fully irrigated and fully navigated. At this point, I am not looking at the patient at all. We're looking only at the computer screen. We're staying on target on the bullseye on the left. One of the great advantages of the software, we can increase the virtual length. We can actually change the plan within the surgery with minimum delay to the procedure. And we do this so we can actually advance into the sinus cavity. So we're now at the sinus floor, and we're going to start the orthodontification process. So when we start first with a 2 mm densa burr, counterclockwise, at 800 RPM, fully irrigated, fully navigated to the sinus floor. And we're staying on target on the left, and we have real-time visualization of the anatomical structures on the right. We continue increasing the virtual implant length by 1 mm, so 1 mm increments into the sinus cavity. Again, one of the great advantages of the software is we can change the plan within surgery. So we continue with the densa burr sequence. We now are using the 3 mm densa burr. We're fully navigated, counterclockwise, fully irrigated, and continue at 800 RPM. I am checking now for the accuracy of the 4 mm densa, and we're fully navigating it. Again, same thing, 800 RPM, fully irrigated, counterclockwise. So you can see here we're staying on target, and one thing that I want you to appreciate is we're fully navigating this, and look at how parallel this drill is, this actually densa burr is in relationship to the occlusal fold of number 13. And this is the condensation achieved on the apical portion. We're now ready to proceed with the sinus grafting. We deliver the bone graft with a cannula, and we help ourselves with a condenser. And then from here, we're going to use the 4.3 mm densa. Again, counterclockwise, now at 150 RPM, no irrigation, yet fully navigated. So we're propelling the bone fully navigated into the sinus cavity. You're going to see me here shortening that virtual implant. And I am doing that so I can tap the site. And the reason is a twofold reason. One, I have selected a non-tapping implant in this case. And two, the compensation acquired both laterally and apically will not allow me to place the implant if I did not tap. So we calibrate the tap, and we check for the accuracy in all surfaces. The buccal, the occlusal, the lingual. And we're going to fully navigate the tap to the sinus floor. So we're staying on target. Again, appreciate the real-time visualization of the anatomical structures on the right. You can see the sinus floor, you can see the adjacent tooth. And now you can see here the parallel pin in relationship to number 13. We're now ready to place our implant, which we will calibrate as well. And we're going to fully navigate it in. Again, I'm never looking down at the patient, I'm always looking at the screen. The only person who's looking at the patient is my assistant. And we're staying on target, fully navigating the implant in place. And you see here the implant in place, very parallel to the adjacent tooth. And you see the compensation achieved on the apical portion, on the sinus cavity. In our second case, we're going to review Transcrestal Sinus Augmentation in combination with the hatch reamer technique. Now the difference between the two techniques is with occlusification, you're using the patient's own bone and you're condensing it laterally and apically. So it's basically a non-excavating technique. With the hatch reamer, it's different. What you're doing is you're creating a hatch through a procedure called the cut, lift, and elevate. So you create a hatch in the sinus floor, and then you actually propel the bone through that hatch. So in this case, Ms. Nigel was referred to us to provide her with first molar occlusion bilaterally with implant-supported bridges. I am presenting tonight only the areas number 3 to 5, and we're going to follow the same steps. We first will acquire the CBCT, and then we will take an intraoral surface scan. And with the intraoral surface scan, again, what we're doing is creating an ideal virtual restorative plan for an implant-supported bridge in this case. We then merge both the DICOM file and the STL files into the software. Here I don't have such a generous amount of bone as the previous case, so I'm staying at 3.6 millimeters from the crest of bone at this point. And we're again going to deliver an implant-supported bridge as the ultimate restorative treatment plan. So we follow the same steps. We have calibrated the tracer tool. We do the trace registration. Again, 100 points are traced per tooth, or per landmark, I should say. The more landmarks you choose, the better, more accuracy you can obtain. And here we're checking the accuracy, and we do that in all planes. We do the buccal, the occlusal, the lingual. We're going to do the drill axis, the drill tip calibration, and we're going to check for the accuracy of the first drill, which is the pilot drill. And again, we do that in all surfaces. Every time you change the drill, you want to check for the accuracy. You want to calibrate and change the accuracy. We will then start the osteotomies. And we're doing both implants, number 5 and number 3. So we alternate. We go from 5 to 3, 5 to 3. On the area of number 3, again, we're staying fully navigated into 1 millimeter from the sinus floor. And we continue the drill sequence. On the area of number 3, we're going to start using the first hatch reamer, which is a 3 millimeter hatch. And we're doing this to create what is called, again, the cut, lift, and elevate the hatch into the sinus floor. We're doing this at 40 RPMs, fully irrigated and fully navigated. And through that restorative virtual plan that we have created. So we complete the osteotomy on the area of number 5, and we initiate the bone graft on the area of number 3 using the hatch reamers. We're propelling the bone with the hatch reamer as we advance. So here we're completing again the area number 5. We're fully navigating it in. We're calibrating now the width of the next reamer, which is a 4 millimeter reamer. This is one of the advantages of the navigational software as well. You can see the representation of the increased width of the reamer in the graphics. And now we're going to lengthen the virtual implant so that we can continue basically preparing the bone and place both the implants. And what a great advantage from the navigational software is that we can change the plan within surgery. And here you have both implants in place. You see the augmentation obtained on the area of number 3 and how parallel the implants are to each other. They were fully navigated and very precise in place. Our last case is a transcrestal sinus augmentation, again combining both navigational technology with the reamer-mediated technology and technique. In this case, we have a single tooth, number 13. Mr. Myers fractured and lost his tooth 1 year ago in Florida. And we proceed to do the same. We acquired the CBCT, the intraoral surface scan. We create our virtual ideal restorative plan. And we merge both the DICOM and the STL files into the software. Here I have 6.6 millimeters of residual bone height. So I'm staying 1 millimeter short at 5.6. And creating the plan, the osteotomy and the placement through that virtual restorative plan. We scan the barcodes. We do the tracer calibration, the trace registration. If you notice here, I actually have 5 landmarks chosen. And we're, again, tracing 100 points per landmark. This is the only time you see me looking at the patient and not looking at the screen. So then we're going to, again, verify the accuracy of the tracing in all the planes, the buccal, the occlusal, the lingual. And we're going to initiate the osteotomies. We're checking the accuracy of the pilot drill on all the planes, every single time, to make sure that you have a fully accurate. So you're now fully navigating the pilot drill into place, again at 800 RPM, fully irrigated, fully navigated. This is the one and only hatch reamer that I will use in this case. And the reason is this is a 4.1 millimeter implant. The wobbling characteristics of the hatch reamer actually make you under-prepare the site. Otherwise, you end up with a very large preparation and a need for a larger implant. So we're navigating the hatch reamer. And we're basically staying within the plan that we have created. Always fully navigated. Look at my posture. I'm totally standing on the upper left screen. I love it. Ergonomics is a must. So here we're, again, continue navigating the implant. I'm going to start, continue lengthening the virtual plan as we advance into the sinus cavity. Again, this is one of the great advantages of navigational technology that we cannot do with a static guide. So we'll continue with our preparation. We're still using the same hatch reamer so that we can actually continue advancing into the sinus cavity. We continue lengthening the virtual implant. And at this point, we're going to place the bone graft, advance the bone graft into place and place the implant. All right. Well, I have mentioned to you already that we started using navigational technology since 2017. However, I became very active using the technology since March of 2018, and I have since completed 80 cases. And I think it's important to know why. So let's review what are the benefits of dynamic surgical navigation. So we know that it has an increased accuracy and precision. I demonstrated that through the publications where the accuracy and precision actually is greater than on static guides and freehand. We can eliminate the need for static guides. We all have to honor techniques and technologies that we have learned. However, we also have to learn from the disadvantages of what we learn. And for the static guides, we know that not only, especially in the posterior region, they can be bulky, difficult to access. You have to have a special keys and a special surgical kit. It actually has decreased irrigation to the site, decreased visualization, decreased tactile feel. And certainly you cannot change the plan within surgery. You cannot change the plan, period. Once you actually establish your plan, you're set. So if you plan to change your implant either brand or diameter, you can't. So as the name is, it's a very static solution. Now the next advantage is that it's fiducial or stent independent. Now this particular advantage is unique and is only true for Navident. No other navigational technology is fiducial independent currently. The advantage of being fiducial independent is you do not have to couple the fiducial to a stent. And the second advantage is you don't have to take a secondary CBCT. The next advantage, it is that the software is extremely easy to use. I am sure that all the softwares for all the navigational technologies are very easy to use. However, I can only speak for Navident, which is what I use. The digital workflow is very simple. You saw me when I was doing those cases. You merge the DICOM file, the STL file, and if you do not have an intraoral surface scan, you can also use the virtual crowns from the software. Now, one great advantage that is important to mention is the versatility of dynamic surgical navigation. It is actually implant manufacturer independent. It is CBCT independent. And one unique characteristic that is only true also for Navident and not for the other navigational technologies is that it's handpiece independent. You can adapt it to your high speed, your low speed, and your piezo. So it's a great benefit for Navident in particular, but again, for all the other navigational technologies, you can adapt it to different technologies as well. Like I was doing on the cases I presented, I adapted it to the DentaVer technology and the Hatch-Reamer technology to obtain the Transcrestal Sinus Augmentation. Now, one important advantage from dynamic surgical navigation in general is that we can change the plan within surgery with minimum delay to the procedures. Again, something we cannot really do with the static guides. Additional benefits include the real-time verification of the restoratively driven implant osteotomies and implant placement. As you saw me on the cases, I was actually working through my restorative plan, and I had real-time verification of what I was doing. Also, real-time visualization of my anatomical structures. Again, looking back at those cases, you saw I was actually creating the osteotomies, how I was able to see where my teeth were in relation to the osteotomies, also where my sinus cavity was in relationship to my osteotomy. The ergonomics, it's excellent. It improves the clinician posture. As mentioned, you're looking not at the patient, you're actually facing the computer screen. So the posture is magnificent. And I wish we can do definitely all surgical procedures with dynamic surgical navigation. The patient experience, it definitely brings a wow effect. Our patients are mesmerized by the technology and the incorporation of the digital workflow. Patients who speak, they speak to their friends, their family, and of course the clinicians in general. So you might be wondering, why did I choose one navigational technology versus the other? Again, why did I choose Navident versus the competitors? Well, in addition to all the benefits that I just expressed, I chose Navident because of its portability. It's actually a technology that I can move from one office to another, from one room to another. For me, that is important because I have 2 offices, so I need to be able to move the technology from one place to another. Second, the clinician support. This is a technology with a company that truly believes in clinician support and that truly believes in delivering optimal patient care. Now, the next 2 advantages, we already mentioned them, and those are the 2 main reasons why, from the system, why I chose Navident. It is fiducial independent and it is handpiece independent. As mentioned, it is handpiece independent. I can adapt it to my high speed, my low speed, and my piezo. And it is fiducial independent. That means I don't need to take a second scan. I don't need to adapt it to a stent, the fiducial per se. And needless to say, for its accuracy, I showed to you, I proved to you the improved accuracy over the other navigational technology, over the static guides and the free hand. How much more accurate you want to be. I will tell you, I don't take risks for my practice or my patients. I find resolutions, always investing on the very best to deliver optimal patient care. So given all these benefits and everything I just showed you, we should have no excuse to be doing these type of procedures without the dynamic surgical navigation. You know, I know that all of you are clinicians. We are all always looking for the betterment of our profession and delivering excellent patient care. Dynamic surgical navigation will definitely take you to the next level. I love this quote by Jonathan Ive. He's the Chief Designer Officer at Apple. It is very easy to be different, but it is very difficult to be better. You want to be better? We'd love to see you at the hands-on workshop on dynamic navigation for implant placement, where Dr. Zagrut, Dr. Mandelaris, and myself will be collaborating at the American Academy of Periodontology in Chicago in November. This is our team. I am so proud of them. They have been in this journey of dynamic surgical navigation with great motivation. Much like the Navident team, we have feel very greatly supported by both. If you have any questions, if you want to visit our office, if you want to come and watch us working, we'll be happy to have you. We are located both in Tacoma and Gig Harbor, Washington. Thank you, and thank you again, everyone, for taking time away from your busy schedules tonight to learn a little bit about dynamic navigation. I can take any questions at this point.